Greetings, Farm Dave here with another Healthy Butthole Journal Club. Today we're looking at POISE 3.5, which was published in August 25th of last year. I call it 3.5, we'll talk about that later, but this article is Hypotension-Avoidance versus Hypertension-Avoidance, Strategies in Non-Cardiac Surgery, an International Randomized Control Trial. The agenda today, we're going to look at the introduction, what's the background and purpose of this study, then some literature reviews, looking at POISE and all their different iterations, and then some other recommendations that are currently still in guidelines. The methods of the current study, including its design, interventions, and the outcomes they looked at, the methods, inclusion, and exclusion criteria, of course, the statistical analyses, results, and a discussion. So the background, roughly half of American adults having a non-cardiac surgery, which I abbreviate NCS, a major non-cardiac surgery, have hypertension, and most of them are taking hypertensive medications. Hypotension is a clinically significant symptomatology occurring in a quarter of these patients postoperatively, and perioperative hypotension is associated with an increase of vascular complications and death. Looking at the literature review specifically of this POISE group, we're going to look at POISE 1 through 3. So POISE 1 was a randomized controlled trial comparing metoprolol extended release to placebo in non-cardiac surgeries with an experimental group that was only 244. There was a noted statistically significant reduction in the composite of cardiovascular death, heart attack, or cardiac arrest. The POISE 2 trial looked at randomized controlled trials comparing aspirin versus placebo in non-cardiac surgeries with an experimental group of 351 patients, a primary outcome being the difference of composite death, non-fatal MI, and no significant difference was found between the experimental groups. POISE 3 was another randomized controlled trial which was comparing tranexamic acid versus placebo in non-cardiac surgeries. The experimental group was now up to 4,757 with a statistically significant superiority versus placebo for the primary outcome being a composite of bleeding events. This trial, which I've called POISE 3.5, is the same study population as the POISE 3 trial, only that the participants also met the specific inclusion criteria for this study as well. Looking at other current standards, current because I don't think most of these are current, and standards because practice is very different from what the guidelines will say in the surgical setting. Looking at beta blockers, in the absence of hypotension and bradycardia, they should be continued perioperatively. This was established in 2009 and is still often seen in practice today. Alpha blockers may be continued but should not be started perioperatively. This was established back in 1982. Calcium channel blockers, again, may be continued perioperatively. ACEs and ARBs, you're typically going to hold these newer medications unless the patient has current congestive heart failure or poorly controlled hypertension, and then diuretics are usually held perioperatively and resumed based on fluid status and past medical history. Again, an older study in 1998. Looking at this POISE 3.5 trial, the interventions, so the perioperative groups, were either antihypotensive or antihypertensive groups. So the antihypotensive group has a lot more criteria about when they're adding, stopping, and changing somebody's antihypertensive regimens. So specifically, if their blood pressure systolic was 130 to 159 and a heart rate greater than 55, patients can take their normal beta blocker dose if chronic. If the systolic blood pressure was greater than 160, less than 180, they should take one of the following medications and in the following order. Beta blockers, if calcium channel blocker, non-rate controlling calcium channel blockers, including amlodipine, nifedipine, thiazides, and thiazide-like diuretics. After the thiazides, they include potassium-sparing diuretics, vasodilators being hydralazine, alpha blockers such as prazosin, then alpha-2 antagonists such as clonidine, aldosterone antagonists being spironolactone, and loop diuretics. This is a hierarchy of what they recommended to start in order for these patients. The third step was if patients had a systolic greater than 180, take up to 3 of the antihypertensive medications that they take chronically, except the ACE/ARB or renin inhibitor in the same order as above. Only here is it okay for a patient to take a combination pill. Only at step 3 in this perioperative intervention group would they accept a combination. At no point should a patient be given an ACE-ARB or a renin inhibitor per the antihypotensive group. The antihypertensive group, they just had a target of maintaining a MAP at least 60 and continuing antihypertensives perioperatively. Looking at the design, so what we're going to look at first is those outcomes. The primary outcome was the 30-day post-randomization composite of vascular death, heart attack, stroke, and cardiac arrest. Secondary outcomes and endpoints include the individualized components of that primary outcome and all-cause mortality. The tertiary outcomes include 30-day occurrence of non-fatal cardiac arrest, hemorrhagic stroke, non-hemorrhagic stroke, acute injury, new renal replacement therapy, new acute congestive heart failure, and new clinically important AFib or sepsis. Inclusion criteria include those who were over 45 years old, undergoing a non-cardiac surgery, expected to require at least one night inpatient post-operatively. They had to meet at least one of the following criteria: BNP of at least 200, coronary artery disease, peripheral artery disease, stroke, or any 3 of the following: major non-cardiac surgery, congestive heart failure, transient ischemic attacks, type 2 diabetes, an age greater than 70, hypertension, serum creatinine greater than 2, tobacco use disorders, or urgent operations. So any 3 of these would count as a criteria that meets one of these. So any of these and they're lonesome, or a combination of 3 of these. Exclusion criteria include cardiac and neurological surgeries, planned use or sensitivity to tranexamic acid, low risk procedure, creatinine clearance of less than 30 mL per minute, a history of seizures, pheocytochromia, thyrotoxicosis, recent stroke, heart attack, or acute thromboembolism within 3 months, subarachnoid hemorrhage within 30 days, or any history of hypertensive related hemorrhagic events. Pregnancy, previously enrolled in a POISE trial, congestive heart failure with NYHA class greater than 3, or LVEF less than 30, an untreated brain aneurysm, or hemodynamically unstable or requiring vasopressors during surgery. Looking at the statistical analysis, intention to treat principle, where all patients that were randomized were included in the final calculations. The sample size calculation equated to 6,500 patients. The outcome analysis was per a Cox proportional hazards model, and all analyses were reviewed using an independent data and safety monitoring committee for each quarter of the project's course. Jumping right into the results, we're going to go over the baseline characteristics and standard deviations for these different groups. So the antihypotensive group had 3,742 patients, where the antihypertensive group had 3,748. The demographics were super spread well, based on their characteristics, an average age of 69.8 with a deviation of 9.3. Women encompass 44.3% of the patients. Past medical and history includes 31% with coronary artery disease, 38% with type 2 diabetes. Hypertension was present in 98% of patients, active smokers 22%, AFib 9.5%, cancer 28%. Baseline objective values include a serum creatinine of 0.99, BNP of 440, blood pressure of 140 over 77.5, and a heart rate of 74.4. The number of antihypertensives that the patients were on at the time of randomization is 1 for 36.5% of patients, 2 for 36.5% of the patients, and those with 3 or more antihypertensives at 27.5%. The surgery was 11% of the time emergent and 80% of the time these types of surgeries, so intraperitoneal, intrathoracic, retroperitoneal, or major orthopedics. Looking further into the demographics, I broke it down by what medications they were looking at, and then also what the surgery types were. The most common medications that patients were on were those ACEs and ARBs, beta blockers, dihydropyridines, etc. So surgery performed most often was a general surgery, and they go into the types of anesthesia, which is not really critical to this talk. Looking at the results for the primary outcome showed no statistical significance, and rather than reading through all of these outcomes, you'll just see that none of them showed any statistical significance between the hypotension avoidance group and the hypertension avoidance group. The next slide is the Kaplan-Meier curve for that primary outcome. Again, you can see why there was no statistical significance established. These lines are very close to each other. At no point do they start to deviate. Looking at the pharmacological results of these trials, we see that something that was pretty interesting is the mean adherence was relatively low. I don't think this is a limitation of the trial necessarily. It's just that in the actual interim around the operation, surgeons had a lot of say on what was continued and what wasn't, and the trial language left it pretty open-ended, especially in the hypertension avoidance strategy. Hypotension, you see a 68% on the day of surgery, maintaining around 74-72% in the postoperative days 1 and 2. Hypertension avoidance groups, we see a little bit lower with 56% on the day of surgery, and then 66.7 and 70.4 respectively, and a 30-day follow-up successful in 99% of participants. Looking way further at the data that they have in their supplementary appendixes, we can see what antihypertensives were held on the days of surgery or given in that regard. Again, not really going to go in here because there is no statistically significant or relevant findings from these. You can see in the antihypotensive group much less of the ACE and ARBs as per the study protocol, but then besides that, nothing that's too relevant. Table 4.7 in the supplementary appendix showed that there was increased adherence to the specific hypertension strategy, also increased the effect towards the primary outcome, however it was insignificant. Table 5 in the supplementary appendix showed that the systolic blood pressure differed significantly between the groups by 1 to 1.7 millimeters of mercury. You can make claims as of the clinical significance of this difference in the systolic blood pressure being very minimal. Tables 8 and 11 of the supplementary appendix showed that the heart rate did not differ significantly between the groups, and table 10 showed that there was no difference between the need for IV fluids, vasopressors, or mechanical interventions between these groups. They further broke these down by subgroup analyses, but like all of their other data, they do not see any statistical significance between the antihypotensive group and the antihypertensive group. So the author makes the conclusion based on all of these findings that in patients with a non-cardiac surgery, our hypotensive avoidance and hypertensive avoidance strategies resulted in similar incidence of the major vascular complications. However, in discussion, I do feel that there is some strengths and limitations of the entirety of the study. So strengths, this is an important, largely understudied topic in healthcare as it relates to surgical interventions. As we saw, a lot of the data that we are still operating on is from the 80s and 90s. There is a massive population that they assessed for this study, and then I did like that demographic table where everybody was so close to each other, so I put the sheesh face here. Limitations, however, are probably more significant in my opinion. This trial, as I've labeled it, the POISE 3.5 is a piggyback trial with some very cryptic language and design. So they just recruited patients on top of the other trial they were already doing and then left so much of the trial really open to the investigator's choice when it actually came to what to do during the trial. I would say that the hypertensive avoidance group, or that I've been calling the antihypertensive group, it's overstated. In reality, they should just call that the minimal intervention group, where they try to just keep people on their meds. It is not something that's really trying to avoid hypertension. In no way is this experimental group preventing hypertension. It's just saying keep them on their same regimen. I also feel that there is no significant data that a provider can actually act upon that was generated by this study. And it is important to note that the historical context of the POISE group has a lot of clinical sites that are somewhat dubious, being excluded from the trial data for corruption and other concerns, and then even PIs being involved in the POISE group that found similar controversy. In particular, if you want to look up one controversial PI, look up Don Polderman in the POISE 1 trial. So based on what we've discussed, my own personal conclusion is that patients who are undergoing non-cardiac surgery, a dynamic approach to maintaining their hemodynamic stability trumps a numeric or stagnant target target for the prevention of major vascular complications. At the current state of data, clinical judgment is the most important factor for improving hemodynamic outcomes in non-cardiac surgery patients. I've included references here at the back, and I would look forward to hearing any questions or concerns from the peers in the audience.